Welcome to this episode of Two Lost Souls podcast. My name is Ravi Amrath, and today we will be discussing all things veterans' mental health with Samuel Thompson. Joining me in the therapy room, as usual today, is the superb Michelle Sudbury. Hi, Michelle. How are you doing?
Hello, Ravi. I'm good. How are you?
I'm good. This feels like getting the band back together, right?
It's been a long time. Yeah, my band t-shirt doesn't fit anymore. I'm going to need to get a bigger one.
How's life been while we've been on a bit of a hiatus?
Yeah, it's been busy, really busy. Lots of good things happening though, and lots of changes in the service, but pretty good overall. How about for you?
Yeah, same. So with changed trusts, we're trying to change our behaviours in line with other services in the area and make sure everything's nice and consistent. Which is, any change is an interesting process. Well, yeah, I think fun is an interesting word for it. But it's going all right. As usual, to any listeners out there, if you would like to hear us cover any particular topics, please feel free to get in touch with us on the usual email address, which is twolostsoulspodcast@gmail.com, or we are still on X, formerly known as Twitter, at TLS_pod. So feel free to message us on that or at us on that if, the place is not on fire. I'll be honest, we don't log into that one very much now. We're also on Instagram as well. So if you want to look up TLS_pod on Instagram, DM us there. Feel free to do that. Essentially, if you just type in TLS_pod, you will find a whole host of different handles that should hopefully lead you to us and being able to ask what you would like to see covered on the show. We have the pleasure of being joined in the therapy room today by Samuel Thompson, who is a veterans therapist and registered mental health nurse for Veterans NHS Wales. Welcome to the show, Sam. I'm wondering to start with, could you just give us a brief rundown of your career today and I suppose how you got interested in veterans mental health?
Yeah, thank you, Ravi, and thank you, Michelle. Thank you for having me on today. I guess kind of bit of a long question really to where to start, but I graduated as a mental health nurse in January 2016. I worked on an adult acute ward for just under a year. Then I worked at the CAMS ward for just over a year. Then I took a year out and worked in Sydney, Australia for a year. And I was, obviously, as a mental health nurse, I was always looking for something else to do, and I've always been interested in CBT. CBT was something that during my nurse training we used to have guest lecturers would come in and they'd talk about CBT, but I guess, and I'm sure we can relate to this, you kind of have an idea what CBT is, but you don't really know what it is until you do it, until you see it. And one of my sort of management placements as a nursing student was on a CAMS community ward, a CAMS community area, and I got to observe a CBT session with someone who was like an associate mentor, so I got to observe CBT there. And I look back and it was a young person with agoraphobia. I obviously didn't know what it was at the time, but now looking back with the CBT, it was really interesting. It was really interesting to see that, and I found it, was really effective. And that sort of stuck with me when I went on the wards and I went travelling. And then I was on a night shift. I was in Sydney. I saw CBT trainee post come out in NHS Jobs, and I was like, oh, I'm going to apply for this. And when I came back after my year, I applied, fortunate to get an interview, even more fortunate to get a place, which looking back now, seeing how much competition there is with sort of CBT trainee posts. And, I was probably a little bit naive to kind of the competition there. And so I was grateful. So I was a trainee CBT therapist for a CAMS community team in Wiltshire. And I was there for about 4 years or so. So I was there, I started the course in sort of February 2019, did this training, and then obviously we had a lovely pandemic to go into. So all of it was sort of face-to-face learning, and then it was then we had to sort of shift to remote working and that kind of thing. So I was there till about end of 2023, and then I was just looking for a bit of a change really, and then I just sort of looked into NHS jobs as you do, and basically a post for veterans therapists came up. And I remember looking back to, I talked to a manager at Victoria about this now, but the job advert didn't really sell it. But I rang and spoke to Victoria and said, can I have a chat? And she went, she really sold the service to me. And I guess kind of military is kind of something I've always been interested in anyway, even as a, as a young, basically a kid really. I was always been interested in history, did well in history GCSE. And, I've had sort of great grandparents who've served in World War II. So I've always had some sort of military interest anyway, but it was just a job that sort of opened up, and it just sort of, it's one of those things in life that sort of, it came at the right time. And then, I work for Veterans NHS Wales now in South Wales, and it's just really good to sort of use the skills I've learned from a campus perspective, transferring it now to veterans, and aside from that, I do a little bit of private work as well, but it goes a long way really. And now I'm part of working with veterans, and it's kind of opened my eyes a lot more to kind of different clinical presentations, different complexities, and overall it's really rewarding. And I wouldn't change it really.
That sounds like a really interesting and amazing background to have for this. And I'm wondering, Sam, I mean, you mentioned there that, the initial advert for this post didn't really sell the role to you, and that you had to get in contact and have that informal discussion. There was a bit of a sales pitch there, which really hooked you in. What was kind of missing from that initial advert for you? And what was that sales pitch that kind of won you over for this role?
I think just getting over kind of the clients that we work with really, because obviously we know what a veteran is and who veterans are, but I think when we realise kind of the mental health need of veterans, it's really kind of underexplored. I think it often gets sort of played down a lot. As we know, if we know sort of family or friends who serve, a lot of people don't like to talk about their experiences, and we know that's can be quite tricky. And I think I think what's good for me is, and how my manager was telling me about it, is because it's a specialist service that we work in, and it's and there's a reason why we have a sort of specialist service, and why it's important that we continue to sort of raise that awareness of working with veterans' mental health and continuing to do what we do. I guess it's kind of one of those areas where there's so many different ways to avenue. Every veteran's different from the next. There's no set way of working. You can't assume that, right, we'll use this approach, this will work. And, I'm fortunate, in the team I'm now trained in EMDR, so you can use EMDR as well as CBT. Not that I'm just going to plug EMDR because that'd be a different podcast, but it's just, you've got a few more tools to use really, and it's good to sort of use that because veterans can be quite complex. They cannot be, but it's being mindful of, I guess, kind of how Victoria saw it to me was kind of a service and the needs, and it is incredibly rewarding. Like today, I bumped into a former client in the supermarket, and he got chatting, and he was just telling me how well he's doing, and at the end he said, "Oh, thank you," and he walked away. And this is like an older gentleman as well, so it left me feeling good inside. I'm going to be honest, but it just highlights this is someone who's never come forward really for therapy before, and that's why we're grateful for the service we got and the clients we work with. Really, it
sounds really, really rewarding. And you mentioned the need of veterans. I suppose when people think of veterans and mental health, the immediate big flashing neon sign that sometimes exists is trauma, PTSD. But I'm wondering, alongside that, what are the most common presenting problems that you face? What are the symptoms that usually get reported by veterans presenting for mental health treatment?
Yeah, it's a really good question. This kind of in itself is a barrier to some veterans, because some will come forward and say, I know I've not got PTSD, but I've got depression since leaving the military. I've got anxiety, I've got social anxiety, OCD. Some clients kind of like body dysmorphia, phobias. We do a lot of work around sort of low self-esteem. I've seen, especially the last year or so being in this role, there's kind of a lot of veterans with like perfectionism as well, kind of really high standards. And we've used CBT to a really good effect. We wouldn't say it's always PTSD, and we tell clients that as well, because some will say, I don't know if I'm right for this service, I don't have PTSD. Obviously we know that the clients we work with, you're more likely to get a common mental health disorder from being in the military, and also more likely to get PTSD from serving in the military as well, especially in a frontline role. You're more, I think it's around 20% more likely to get PTSD, as opposed to, I think the general population is about between 4 and 5%. So it's significant. And that's what we know as well. And that's another layer to it, is that's what's reported and that's what's known. So we think of people who are trained in that sort of environment, not to show emotion, not show, because, showing emotion is a sign of weakness. They hold it in, and they go through life, things happen, and then things just come to just like a big eruption, really. And then they go, oh, I don't know why I'm thinking like this, I'm feeling like this. And it all just comes out. And I think that's another thing as well. If they did experience or witness trauma or traumatic events or whatever presentation is, it's unlikely it would have been reported then, and they take that when they leave. So I think the figure's probably a lot higher, and I'm sure other people who work with veterans will probably agree with that.
You mentioned there that big flashing neon sign of PTSD can sometimes form a barrier in terms of some veterans, if they don't have PTSD, for example, thinking, can I even get treatment for anything else because I'm not traumatized, and that's what they'd be looking for. I'm wondering, what are the other barriers, obstacles, challenges that veterans face in terms of accessing services, and I'm wondering how that also impacts on the therapeutic journey after they have finally managed to enter a service.
I think one of the biggest challenges is actually healthcare professionals knowing there are specialist veteran services around. So in the United Kingdom, there are veteran-specific services, and what tends to happen is a lot of veterans who are struggling, or for whatever reason, they might present to the GP. The GP might not even know they're a veteran. They might not even say they're a veteran. They might say, I'm feeling like this. I don't know what's going on. I don't know what's happening to me. They will go then to sort of have a talking therapy service or like a primary care service in Wales. But they'll go there, and then they'll then get assessed there, and then people on a waiting list for treatment there. And like we know, the waiting list for treatment in talking therapies, primary care is quite long. Things might snowball, things might escalate that way. But one of the things we're trying to, and I think anyone who works with veterans and any veteran-specific services, to make sure that they can come to us, especially if it's military-related or it's something from military. Now, that's easier said than done because, when we say military-related, well, what does that mean? And I think sometimes it's all about the semantics. I think if there's anything where the military service has affected their mental health in some way, that would meet the criteria, and we would offer an assessment. But like we talk about the patients and the client's needs, it's kind of, well, they've gone through the GP, they've gone through an assessment in like a talking therapy service, then they'll come through to us for an assessment. That's 3 lots, maybe even more, depending on clinicians and who's available. So, that can be one of the many challenges, is kind of the system that's there, and that's why we're always trying to raise that awareness. And I think I found with our service, people kind of know us, but don't really know what we do and what we're about. And I think it's just continue to improve, recognise that awareness and recognise that there are veteran-specific services in the UK, and if you're not sure, go to GP, have a Google, ask as well. One of the best things that does help us, and this is my experience, is if a veteran's come through our care, had a good service, they recommend it to us, but like TripAdvisor, like kind of like, get 5 stars. But I feel sometimes people don't really know we're there, but we continue to always improve. Obviously, we've got the websites, it's online, but then we find with the older veterans, they don't like the internet. They're not going to, a 75-year-old is not going to really refer online. And that, I think sometimes we can fall guilty of, don't we? We say it's convenient, say, just refer yourself online. Here's the link. Are we going to get that referral? So now we sort of switch now. We have paper referral forms. One of those sort of ways we do also comes from the challenges is we work quite closely with where we are. So it's kind of, there's 2 sort of veteran hubs. So veteran hubs is a place where a veteran might go for kind of peer support. So obviously someone that's not trained as a therapist, often they're veterans who have served, and they've got maybe lived experience of mental health difficulties or even just experience in military. That can be really helpful getting people in. Like I said, it's not easy for anyone to come forward for treatment, but, to get a veteran in, and the two sort of veteran hubs in Swansea and Port Talbot. So one's at Swansea Veterans Hub and the Bulldogs Boxing Gym are both really good for helping getting people in, getting people talking, just being a nice, that kind of calm environment. And then that can also be one of the ways we can overcome that barrier as well. So many barriers that it's there, but we're just trying. I mean, one of the most recent ones is we've noticed in our service, we were having a chat and noticed we got a lot of referrals from people who worked in the NHS. So, we've got the intranet in the NHS, so we created a page on the intranet. So, because most people think, what's this service? I'll Google it. Okay, you go into there, then you can refer yourself in that way. So a project that sort of Victoria and Anna in our team are doing is encouraging GP referrals, but also trying to encourage that self-referral and referring in. Just lots of ways to try, really, because it's not easy, it's not straightforward, but we do try.
I think one of the things that is quite common amongst veterans are relational issues that impact on mental health. So we know that military personnel are much more likely to go through things like marriage breakdowns, divorce, also addiction as well. So alcohol, gambling, addiction to physical exercise, those things.
So at the moment, is your organisation only offering CBT, or are you looking to kind of expand that out a little bit into some of the interpersonal therapies or counselling approaches?
There's always scope to explore that. I think I found it. We currently offer sort of CBT, EMDR, and then cognitive processing therapy. So that's kind of, obviously, for those who don't know, it's CPT, which is confusing for clients as well, CBT and CPT. But like I say, CPT is when you look at sort of stuck points and stuck beliefs, and you look at it from like an alternative perspective. And especially if clients are particularly distressed about going through that process some trauma, that's when CPT can work really well. There has been talk about sort of further training. I know one of my colleagues in Cardiff is trained in IPT, so that looks into kind of a lot more kind of the interpersonal stuff in relationships, which I think would be quite useful. But there's always scope for improvement. I think a lot of it kind of our current work is kind of we work with the veteran themselves. We obviously have an idea kind of family and who's in the family network, but there are sort of additional organisations we do refer to if there's sort of family difficulties, if there's like sort of systemic stuff going on. Majority of the clients we do see, they might come with a family member, or they might join for the assessment maybe, but we focus mainly on the veteran. But we are mindful of the difficulty, and like you said, a lot of veterans do have relational difficulties, especially if it is PTSD or any other difficulties that's happened. And some veterans, they have been in several marriages for whatever reason. And often that's the kind of thing they've kind of carried on. So whether they experience in the military or even in earlier life, in childhood, or there's been any sort of childhood trauma, because that's the thing that a lot of veterans we do see in our service have childhood trauma. Then they go into the military, and then they have military trauma, then anything else that comes up. And then they go through life thinking and feeling a certain way, they don't know why they're like this, and they wonder why the relationship's breaking down. They wonder why there's a dependence on alcohol, substance misuse. And we also, like I said, we try and work quite closely with sort of alcohol dependency and substance misuse service as well. So we do try and link in together, but yeah, it's a really good point about the relational side of things as well, because that does have a big impact.
Yeah, we've touched on it a little bit there in terms of relational difficulties, in terms of potential comorbidities and addictions. I'm also wondering, what would you say are the characteristics that might be added challenges when treating veterans as opposed to treating civilians?
I think some of the additional challenges really is kind of, you might have a veteran who's been exposed to multiple traumas. I'm not saying that's just veterans, of course not. It's applicable to anyone in the population, but you do tend to sort of, a lot of veterans we do see do have a childhood trauma or traumas. Then they go into the military, then they have that, then they're exposed to that, and then they might have additional traumas when they've left the military and everything else outside of that. So there's kind of so much going on. It's kind of like things all come to a head. And I mean, I think the research recently, I think it takes about 13 years on average for a veteran to come forward after their military service, and that's a long time. People might have families, people might travel, might do, might see the world, might do whatever they want to do. But I think the challenge is a lot of veterans, and they don't want to come forward. They don't want to getting help. They see it as a big stigma, kind of seeking help, and they think that that they're I have a lot of veterans think that they're weak for talking, weak for getting for seeking help, and it's just kind of been it's kind of working out really. And I think one of the benefits of our service is we can be a little bit more flexible in what we provide. We can be a bit more, we can do sessions outdoors, for example. We tend to try and take things outside the clinic room. We all know, Dr. Nick Gray said, CBTs are doing therapy, not just talking therapy. And sometimes it's one of the flexibilities of that is that you can do a little bit more with clients, do a bit more exposure. You can do a bit more, even just going for a walk and actually using CBT in that sense, and behavioural experiments or testing things, anything you want to do, that kind of works that way. And it's just fortunate to have that kind of option, really. Yeah, because I guess kind of, I think, like I said before, one of the challenges is kind of, obviously COVID, you'd have the internet and online sessions, but majority of our clients now, they want face-to-face. So we use that to our advantage, really. And it's been really good. I think it's just been fortunate to be a bit more flexible with the client, because the client needs, because there is that complexity. And sometimes what can happen is we can have a client come for an assessment and they don't know what's going on. They're just feeling a certain way. They're thinking certain things that, they feel a lot more angry or agitated, or, it's, I think kind of what Michelle said, it's not, relational to employments as well. So we also work with employment agencies because it can affect their jobs if they're going through a cycle of going in and out of employment, and that stress that carries is that, there's a lot more to it. But I guess kind of, I think being in a service that can be a bit more flexible and be able to, I guess, just think outside the box a little bit. But it kind of helps, and it helps to try and meet the needs of the veterans as well. So yeah, I think that's one of the ways we try to do that, really.
Coming on from your last point, one of the things I've noticed with veterans is sometimes their expectations don't always match what it is we offer. So I suppose what I mean by that is, I think there's a real military culture about that kind of instant gratification. I say I'm going to do something, I want it now. And I think my experience is that the expectation can sometimes be, hi, I'm here to see you. I've made that step. Now you do your bit, get me fixed. I need to be out of here within the next few weeks. I'd like to be back to normal. How do you manage that?
Yeah, veterans, regardless of how long ago they served, they still have that kind of that expectation. And I think it does fall back to kind of the high standards as well. They put on us, and I often do say to sort of the veterans who work with, it's not going to be a quick fix overnight. You might need several courses of therapy. Some veterans do expect to be fixed. And I think sometimes that happens in a lot of services, isn't it? Regardless of kind of if you're a veteran, like people expect, like, and I saw it in CAMS as well. You need to, fix my child, or whatever. You need to do this, and it can be, it can be a lot of pressure as well. And I think you're right. We talk about treatment options that we do offer, and they go, like, we know a lot of clients go, well, you're the expert. You're like, you get that sinking feeling, like, oh no, they think I'm the expert. I think a lot of it is. I think it's just being realistic, and I think sometimes it's one of those things that I found as well is being a little bit more honest and direct with clients and saying, we offer these many sessions, we'll review, we'll see how things go, see how you're finding things, and just saying, you can always come back for another course of treatment if you want to, if it's not the right time, or if it's not what you expect. But I think that's kind of usually kind of how I explain. But I do sort of take a lot of effort to build that rapport with veterans as well, because a lot of them do come in quite anxious, actually, which is understandable given the fact that they rarely spoke to anyone or anything about it. But those kind of standards, I think it's maybe something I'm just becoming a little bit immune to, but it's something I try and like be quite open and honest with, and have a dialogue. So look, this is what we offer, and I didn't used to say this, but I say it now, and it's and I think it's helped a lot along the way. And I think, like you said, veterans do like that kind of being that direct, honest. This is where we stand. And I think that's something I've always tried to be quite conscious of, but having that kind of open dialogue and seeing where it goes, really. I think it's helpful, the fact that we do offer more than one course of therapy, and that can be really effective as well. We talk about CBT and EMDR, and CBT being really effective and really helpful. So it's not just relying on one psychological intervention. So that also helps. Sometimes it's a bit of a mix, but it kind of depends on how it goes with the client. But we tend to sort of offer maybe like the initial 6 sessions, then we review and we say, what is going on, what's happening, are they holding back? And sometimes even as honest conversations can really bring down some of those barriers. Are you holding back? I can tell you in the sessions or the process and the traumas, or I feel like you're still holding back a little bit, and then we sort of overcome that. Really, I've got really good supervisors as well, so that tends to help as well. But it is a lot of pressure to put on, and I think it's in it, and sometimes we do take that with us as well, kind of expecting us to completely fix them when there's so much more going on.
I think that answer alluded to it there as well, but earlier on you spoke about the importance of CBT being a doing therapy and not just a talking therapy, which I think a really important takeaway, not only for trainees who might be listening, but also for even seasoned therapists. I'd never be afraid to get out of the therapy room. And I suppose with the modality that we use, we're kind of lucky to have things like exposure, behavioural experiments, all that lovely stuff that allows us to actually get out on our feet and be experiencing and doing stuff in the real world rather than being stuck in 4 walls all the time. It does sound, though, like just by the nature of your service, you get a lot of flexibility, and rightly so, to work with this client group. And I'm just wondering if there are any trainees or any therapists listening who work in places that potentially could be a little bit more restrictive. What would your advice be to them?
See, this is something that I've always sort of thought about, really, because when I did my training, I always tried to push the boat out a little bit with sort of experiments, and I always tried to be quite creative and tried to, I was one that, would like, if it was a young person with social anxiety, we'd go into a shop, ask for something they don't sell, just to sort of, anything like that we'd always tend to do. So I think to be honest, I think if there's anything, it's a big thing to sort of monitor outcomes as well. And I think, if you push the boat out a little bit, it can be quite daunting as a trainee, even as a qualified therapist, no matter how many years, it can be quite daunting to do something when it doesn't go to plan. But I think it's always just being a little bit creative, a little bit thinking out of the box. We've done that before with some exposure work around hypervigilance. So a client would often sort of check bins, so in the street. So we'd go out for a walk, I'd put my hand in the bin, and he would be like, and you could see the anxiety. So we tested out, and that changed a lot of their beliefs about, there would be like an explosive device in there. So we did a lot of work around that. So I think if you're able to sort of think outside the box a little bit, I think that you would see a bigger difference in outcomes. And we can monitor that with sort of questionnaires, psychometrics. We monitor symptom trackers. I'm sure you can, if they can justify kind of just being in that room and just talking about it, and actually let's see the difference when we actually do something. Is there a reduction in symptoms? But I think one of the good things I love about CBT is you can be really creative. You can think outside the box. You can do that kind of, like you said, exposure and behavioural experiments, test out those beliefs. And even when I was in CAMS, I would always put the hand down the toilet for the contamination, as part of the experiment, not just at work. But it was always something that worked really well. Because, like you said, we can talk about it, but it's a doing therapy. But I would say, if you are restricted by sort of service, just try and be a little bit creative, a little bit outside the box. You can do anything outside that clinic room. You can do it, and that's the thing, because it's hard. When you work with clients and things are feeling a bit stuck, you're not sure where to take it. It does make such a difference if you can do it. And I think try and justify that, and you'll see that in there. Because sometimes it's hard for some clients when they have sort of different therapies, different therapists, and you think things aren't changing. And sometimes that's happened to the clients I've worked with, where you might see one therapist, and then nothing's changed, and you sort of see them and things do well. It could just be a bit, but I would say if you are feeling a little bit restricted, try and do something, even if it's in the room, just testing something out that way. If it's something that can change it, I just think it just takes a little bit of planning, just to be a little bit creative, really, and you just go with it. And that's all I'd say.
And to perhaps put this in a slightly twee way, so to all the trainees listening, or even the more seasoned therapists, perhaps the therapists that have been in the system for a long, long time and might be growing slightly jaded, this is your reminder to not lose your sparkle when it comes to planning these sorts of change methods. We'll take a short break and we will be back very shortly. Welcome back to this episode of the Two Lost Souls podcast, looking at CBT with armed forces veterans. A lot of the show today so far, Sam, we've spoken about, I suppose, treatments that exist when people leave the military, and particularly when they're trying to find their feet back again in civilian life. Just from a sort of systemic point of view, what support do armed forces personnel have while they are serving, if any?
When there's people who are still actively serving, there is sort of designated healthcare, mental health teams that are based in different sort of military bases around the UK. So they are known as DCMH. And so if there's a serving military personnel who is experiencing difficulties, whether it's physical health or mental health difficulty, they will often be seen by appropriately trained clinicians who are there based in the bases, really. So you can get support that way. What tends to happen to some of the clients we do see, for numerous reasons, they may not get that support, depending on the circumstance how they left. Sometimes if they leave under a dark cloud, less likely to get help, seek support, or they might not know that help's there. I think that's a big thing a lot of veterans don't know. We've had people that didn't know about us, and one of the things we always try and say to, how have you heard about us? Where, how did you get in contact? A lot of them will say, GP. As soon as we do know, it works well because they know we're there. But yeah, for a lot of serving personnel, there is sort of specialist trained clinicians there who support them. And what can happen is if there's some certain personnel who are in the process of leaving, they do like a resettlement package, which I think is around 2 years, I believe. So they kind of got that support, because the older veterans will say, oh, there was never any support when I left. That tends to be a narrative that's there. But there is, like, I think it's a 2-year resettlement thing now they offer now. But I think like a lot of things, people are a lot more aware, recognise kind of the needs of veterans. So sometimes what can happen is if there is someone who's leaving and there's still further work support, they might do a bit of a transfer to us. And that can happen. It's not common, but it can happen. So yeah, there is that support that's there. It's just, I think that comes down to a lot of things. Is people like overcoming that sort of stigma and the barriers to actually accessing the help that's there.
And I think you highlighted that, didn't you, earlier, Sam? You mentioned that because of the stigma and the kind of difficulties in particularly, I guess, male military personnel coming forwards and getting the help. I suppose what I'm thinking about is here in England, where we have a stepped care model, and what we always try to do when we're promoting mental health services is encourage that kind of early access so that people are seeking support when they're experiencing those mild to moderate symptoms. What I'm imagining, though, just from my own experience of squaddies, if you like, is waiting until things are kind of really, really before they come and seek help. So we're already on that kind of step 3, step 4 cusp when they're proper poorly. Is that kind of the reality of it, or is that just what I'm imagining?
No, absolutely spot on, Michelle. It's the reality, really. It's often for numerous reasons, whether it's the stigma from themselves to seek help, the stigma from what other people might think, like family and friends might think of them for seeking help. Employers, if they've already left the military, can I get time off work to attend appointments? We're always very mindful about attending appointments for mental health and the importance of that. But yeah, often a lot of veterans do tend to be further down the road, like you say, maybe step 3, step 4, when a relationship might have ended, might have just lost a job. They are literally like on the floor in terms of being like it was struggling, and then it's like, and it often, especially for a lot of veterans who have pushed a lot of things down in their life, it just all comes up, and it's like that was it, straw that broke the camel's back, should we say, and that's it. And then often they don't know where to go, where to seek support, and that's where a lot of veterans do end up going to GP, because it's like, well, I need to book a GP appointment, the pressure of getting an appointment, going to the appointment, talking to GP. Hoping that the GP recognises that they are a veteran. One of the things that is recognising that on medical records, it will say veteran status, yes or no. Sometimes we get referrals from GPs that say no, they clearly are a veteran. But yeah, it's often we do see people who are literally in crisis or on the verge of going to crisis or being, quite unwell. I think that kind of like step 2 isn't quite there, and maybe that will change. If there's a veteran who a younger veteran, shall we say, in their 20s and 30s who've done so many years in the service, they will come forward quicker than someone who's older and has done, let's say, and they've done the service like 20, 30, 40 years ago. And I think that's what we're seeing. Maybe it's a bit of a generational shift. So there has been some veterans who recently have come forward for help in their late 20s, early 30s. Which is, I think is a bit more of we're noticing that more now. Maybe that's more of awareness, the mental health awareness, all that stuff. I know we have Mental Health Awareness Week and all that. Maybe that I've seen that's a bigger shift. But like I said, we also do get the veterans, like I said, who are really struggling in kind of crisis mode, stage we say, and some veterans do come forward when it is too much, and they do get referred on to kind of home treatment or crisis team or anything like that. But as I said, our service is, we do outpatient psychological therapy, so there's only so much we can manage and hold as a service as well.
We touched on a few different elements of treatment earlier, and alternative services that people can access. And I suppose you yourself work for a specialist veterans mental health service, but I suppose thinking about the wider landscape, perhaps across the whole of the United Kingdom, alongside talking therapies services, what are the other services that exist to provide support to veterans? And I suppose where would you say, the boundaries are between these services, and when someone would access one as opposed to another?
One of the things that we rely on in Wales is the role of sort of peer mentor. So a veteran, usually a military veteran who's, like I said earlier, has lived experience of our mental health services or just a military experience, and we are trying to work quite closely with them as a service because they can help bridge the gap between, because what we do struggle as a service, as I've not mentioned so far, is people attending assessments, people engaging, and I think they can be the barrier to bridge that gap. You know, if their anxiety, if veteran anxieties are high, they've been let down by other services before, which again is another challenge. If you've been let down by services before, if I mentioned that, it's kind of, that's something that we might work quite closely with. So sometimes if a veteran comes in not quite appropriate for therapy, we might refer to them. So in South Wales we use Change Step, and they're really good. They do a brilliant job of supporting veterans, getting them foot in the door, getting them engaging, getting them talking. But I guess kind of across the UK, you know, there's, like I said, there's other sort of veteran-specific services. There's other charities as well. So, you know, you've got like Help for Heroes, you've got Combat Stress. There's quite a few. There's quite a lot. There's quite too many to mention, but there's often a lot of different charities doing really good work. But I guess it depends on kind of what that client needs. A veteran needs not every veteran might need psychological therapy or trauma-focused therapy or CBT, CPT, EMDR, but I think often sort of increasing that sort of veterans network of support, and that's why there's sort of veterans hub. So anywhere in the UK, there's often a veterans event, veterans hub. I think nowadays being sort of, you know, having a smartphone, you can find that. There's often events on. A lot of people do kind of like outdoor things, so kind of like, you know, cold water therapies becoming like quite popular, that kind of self-care. That was in the news in Wales. There's a veteran called Phil Jones, who's doing a research project on that in Swansea University, sort of trialing that with sort of seeing if that reduces PTSD symptoms. But I guess there's so many going on. There's so many networks out there. People don't realise what's there. And I think often we try to, when we do an assessment for a veteran, we try and tailor their interest. You know, would they like to sort of socialise with other veterans? If they don't want to, fair enough. It doesn't matter. We're not going to force it. But I guess there's loads of different activities and events that people can tailor to. We obviously see the ones who are suitable for psychological therapy, and not everyone is in that place, and that's fine. That's why we use peer mentors, or we might use sort of charities as well, but we wouldn't use it for the sake of it. But we're obviously mindful that, you know, if we can create that network where veterans have got activities, give meaning, you know, I mean, there's like veterans like motorbike groups, there's like veterans fishing groups, there's like, you know, there's anything really that's there, and there's a lot of like smaller charities as well, and it's just the people just don't know about it. People just don't know, and I think that's because for numerous reasons, where people have moved or relocated. We do rely a lot on the peer mentor support because they really help people. Like they come on board. Even I talked about the Bulldogs boxing gym earlier in Port Talbot. They have regular drop-ins. Swansea Veterans Hub as well. They have regular veterans drop-ins, and they network, and they can help us with referrals. Oh, I've just saw this veteran today. Might benefit from having a chat, and that gets the ball rolling that way. Same with the peer mentors. So I think a lot of it is focused kind of on the work that we do. You know, mainly the one-to-one psychological therapy work. But like I say, I think we, you know, I don't know where it would be without that kind of peer mentor, that veteran hub network that we were trying to connect to, and that means then we liaise with, you know, SAFA, which is like a veterans finance charity, Poppy Factory, veterans employment, you know, all the different things that sort of link in. And there's probably a few I've probably forgotten just talking about it now, but we try and like think about the wider network. But yeah, I think if the veteran is not suitable for therapy for different reasons, then we look at alternative ways.
It's interesting, Sam, when you talk about the peer support, and I think really it highlights for me that going back into whilst personnel are still serving in the military, are they really missing a trick? Because one of the things that you've got at your kind of advantage when you're working with military personnel is they're there to do task, right? So you can tell them to do anything and they'll do it if the command is given by somebody senior enough. So in terms of engagement, if the military were able to incorporate mental well-being as part of their training, because you're right, you know, sport is such a big part of most military people's careers. So somebody will do boxing or skiing or, something in the military, incorporating that, the physical well-beings and linking it to mental well-being, and just really talking about it and promoting it so that engagement battle isn't quite so difficult when they leave the military. I think that they're really missing a trick there, and hopefully you're identifying that younger people are kind of coming and accessing support probably more readily or more easily than older veterans. So maybe it is starting to have a bit of a shift. What do you think?
Yeah, no, it's a really good point. Someone else did mention something about wellbeing is a big thing, maybe because we are in South Wales, but is kind of bushcraft and, retreats and stuff like that. There's a few near where we are. There's a client I was speaking to last week. He was showing me where he's got this kind of piece of land. He's made it into like a real like retreat place, so you can sleep, in the woods, and you can make food on the fire, that kind of, and I think that's a big thing as well. There's a big kind of real connection with the outdoors, and especially a lot of veterans like being outdoors, so that's really good. And you talk about earlier about family stuff. The client, the former client I was working, I was talking to, and he, they're promoting it now for like families, and it's not just veterans. Veterans and veterans, is kind of like families can go there as well. There's no mobile phone signal, so you can just reconnect, and it's not going to work for everyone, but it's good. It's good that there's things like that that's out there, and I think, like you said, it's that trend. Hopefully, that's just my sort of observation. I think the younger ones are coming to us quicker. If you took a gap when they left the military to when they referred to us, the younger ones, it's a shorter gap than when being discharged when they're older. So I think there is I think there's a change. I think there is a change. I think that's I do think it's a generational shift, and I think we're working a lot in sort of the sessions, kind of breaking down the sort of the beliefs, the core beliefs, and everything else that comes with it, sort of seeking help and that kind of thing. But yeah, I think I do think you're right. I think there is. I think there's a bit of an adjustment to it, and it's good. It's good to see.
And you've spoken about that sort of generational shift there, Sam, and a change in attitude, but also earlier a change in people's narrative on what happens when they leave the military. So I think, as you mentioned earlier, it wasn't uncommon for perhaps older people who left the military to say that, I was there for my country, but when I needed my country to be there for me, it just left me deserted. And given that there's been this shift, given there's already been a systemic change in the way this is being worked with, I'd invite you now, I guess, Sam, to break out your crystal ball. What do you think the future holds for this area, and where do you think we're headed next?
This question actually gets talked about in our services. It might have been at one of our team away days. It was kind of talked about kind of where the service will go, what will it look like, because like you say, we're veterans who've been in conflict, and with the last major conflict, obviously the British Army, the main one, obviously, was Afghanistan, and that ended about 10, 11 years ago now. So it's kind of what we do see, but obviously, like I said, we do know it takes around 13 years for veterans to come forward. So there'll always be veterans that I think will always need help, and they will always come forward for help. But given the fact that some of these veterans have seen, haven't talked about anything that's happened for about 40 odd years to no one else, not even their partners, I think we'll always have a place. And I think
you'll be busier, Sam. I actually think, even though we haven't had conflict, that we've been actively involved in any kind of large way for a number of years, we're miles away from things like the kind of troubles in Ireland. And I think actually just this kind of stuff, talking about what's out there, has really kind of boomed in the last few years. I can't tell you how many times we've had veteran therapists come into our service to promote veteran therapy. So I think because the support is becoming broader, wider, more accessible, I actually think you'll be busier, even though there aren't perhaps some of those more obvious triggers for things like veteran mental health, because it's the everyday stuff too. Being away from your family on exercise, just having to pack up and move every 2 years. Those things can be incredibly impactful. You don't have to have gone through conflict, do you, to kind of become very depressed. I actually think talking about veteran mental health in the way that services like yours are can only mean that more people will be able to access you and then, become a bigger industry.
Well, you raise, that's a really good point, Michelle, because you raise a point about the barriers. Another sort of barrier is some veterans say, well, I was never deployed. Well, just because you weren't deployed doesn't mean you have to experience a mental health difficulty related to your service. You could experience something on a training exercise. You could witness something when you were there, and that can happen as well. Some people can get through training. There is quite a lot, and I think a lot of if there's any other veteran therapists listening, a lot of veterans have been bullied in the military, and that's coming through now. And also, what's also coming through is obviously before the year 2000. I think it's 2000. It was illegal to be gay in the military. Absolutely. And then you were thrown out. So you think of there was challenges there, and that's only 25 years ago. So I think absolutely right. There'll always be this, but I think we need to know that as a service that we can offer that support. Mm-hmm. You don't have to be deployed I think, unfortunately, that's kind of the myth of the military, and that kind of, I guess, kind of expectation. You must be on the front line. You must have been exposed to stuff. You must not. There's kind of must really we see. But you can be. We work with clients who've never been deployed or who couldn't complete training. And they live their life knowing that they've not completed training. Don't think they're good enough, and we work through all that as well. So you're absolutely spot on. You're absolutely spot on, Michelle. It's kind of it's not. It's so many different things, and that's what we say. Because that's one of the things some clients will say to us, in the assessment, I know I've not been deployed, I know I haven't got trauma, that kind of thing. And
minimising it,
yeah, of course, and we know what happens when we minimise things. It just keeps, it escalates.
You really put it really eloquently in terms of busting that myth and saying, look, you don't need to have been deployed in order to obtain therapy or in order to be experiencing any kind of difficulty with having left the military. And I'm also wondering how many veterans, I'm guessing quite a few, tend to not only suffer from that loss of identity in terms of this is who I have been, this has been me as an individual for however many years I'm doing it, but also I'm also wondering for how many people the military has also been a coping mechanism in its own way. And I suppose what I mean by that is that I've seen some statistics recently that the most popular profession for females who experience symptoms of ADHD is teaching, and that's simply because everything's structured, right? There's a timetable, you kind of know what everyone's doing at what stage, and everything hopefully runs to clockwork, right? And I'm wondering how much of that there is in the military in terms of people with neurodivergence looking for some way to kind of contain that and attain some way of adhering to structure or routine. And I'm wondering how that either might compound that issue or how you deal with that added challenge on top of that.
Yeah, absolutely. That's a really good point. And that's and I think that's it, when there are some veterans who, who are waiting assessment for autism and or ADHD, or they've already been diagnosed. Like I said, the military is very, very structured, very routine. It's very, it's this or this. And a lot of veterans who I've worked with who have said that they found it quite good. They found that they enjoyed having that structure, that routine. And then, like I said, the identity, they sort of missed that when they transitioned to Civvy Street. And I guess we haven't really talked about that kind of transition, because that's when a lot of veterans really struggle, because things are set up for them to be, this is what the military is like. And then as soon as they leave, they get a job or get multiple jobs, or, they find that nothing quite lives up to that, because, you're told that this is the, and it's a kind of very harsh military environment. And I think if you got that, diversity as well on top of that, that can be even harder. But people don't see that. People don't see, they wonder why, there's a veteran who's drinking more, taking more drugs, not maintaining employment, getting angry, getting aggressive. And it's, like you said, it's that kind of transition. Civvy Street's kind of that kind of military lingo that, there's a lot of military lingo I'm still trying to work out, but it's good that the veterans actually tell you what it is, because things can be quite confusing. But yeah, I think when that's not there, it just, I think it takes a long time to find their identity, and I think one of the good things about the sort of the veteran hubs that we have is it reconnects people to, and some people have been, especially in South Wales, two people who are living on the other side of the country met up in the same place. So it's going to be a small world sometimes. People know, I know you, or even then it's, like I said, it's that identity, and it works really well. But I think that transition often gets kind of underplayed a lot, because people see the kind of the behaviours and the and the tricky parts of adjusting. But yeah, like I said, I think that I've often, from working with clients who are neurodivergent, they say that they found the military was good for them in that sense, that it's all about routine, that structure, knowing that this was this, that it helped them a lot. Yeah, it's just when that kind of in a sort of free fall afterwards, that's when things can be a bit tricky.
As you know, Sam, sometimes on this show we like to open our mailbag and listen to some questions, or read out some questions that our listeners have sent in. So we would like you to join us for a segment that we like to call Socratic Questions. Okay, so this episode, we have a voice note question that has been sent in from Alice.
Hi, Chel and Ravi. I'm Alice, a trainee CBT therapist from London, long-time listener, first-time caller. So I had this situation recently. I was working with an armed forces veteran, and they wanted to share something with me about a traumatic incident, but they felt like if they told me, it might actually contravene the Geneva Convention. So I wasn't really sure what to do with that. So I spoke to my supervisor. I let the client know that I'd only need to pass anything on externally if there was an ongoing risk. And in this case, there wasn't. Did I handle that right? And also, are there any specific precautions that therapists need to take when it comes to the Geneva Convention? Like, is that different from general confidentiality stuff? Thank you for all the great episodes so far, and I look forward to hearing more.
Okay, so question from Alice there on confidentiality and the Geneva Convention. We obviously don't like to make the questions easy, Sam. What's your immediate response to that?
Sometimes some veterans will say, I can't talk about it because of the Official Secrets Act. So they will say that. And I guess kind of, for us as a therapist, we're not here to sort of pass judgment really on what's been said. We know that things have happened. We know that veterans sign up, end up being exposed to sort of military, being exposed to sort of combat situation scenarios. I guess to me, it's kind of what would be the relevance of what was being said. Is it, if it's a trauma? Is it a trauma presentation? Is it something related to anxiety, depression? Whatever. What would be the relevance of it? Because we're not here to, and then sometimes some veterans do feel that in our assessments, they feel a bit like they're getting grilled when we ask them questions and we're going through. So I think it would depend kind of what the purpose of it was. And the only other thing I was thinking kind of, would it be kind of a moral injury kind of element to it? Tricky to know with the questions, but it's, because obviously the moral injury does come up quite a lot with military veterans. And I think it's, when they've been exposed to situations that, have affected the moral compass, that they would, could that be an issue? But yeah, I think it really depends entirely on kind of the context of the veteran and, is there any sort of immediate kind of harm? I mean, I guess kind of a layer to that is kind of, I know in the media recently, there's been a lot of investigations from, like I said, from the Troubles kind of about, things that have happened, things that have gone on. So that again, it's just very complicated, isn't it? There's no real sort of right or wrong answer, and I think we can't. It depends entirely on the individual, depends entirely on the context of what's happened and what's going on.
I completely agree, Sam. And I also think as well, I'm a big believer that we can deliver really great, effective therapy without needing the content. So what we what we really need in order to support somebody is the impact, right? So if somebody can verbalise and explain to us whatever's happening for them, whatever's coming up for them, whatever they've done or been involved with, that actually we don't really need to know. What we need to know is, what's this leaving you with? What's this doing? How are you feeling? What's the biggest impact? These are the things that we can support with. Even in trauma work, I mean, I do appreciate that kind of going into the middle of reliving and not knowing what you're talking about is probably going to feel very, very difficult, but there are always ways around it. I remember working with a client some years ago, and he was ex-military, and as a civilian, he had volunteered, and he had gone off to countries where there had been lots of war and disturbance and civil unrest. And part of his job as a volunteer was to clear unmarked graves. So really, really horrific, traumatic, disgusting things that he witnessed. I didn't need to know that. I didn't need to know what he was doing on his day. I didn't need to know what he was seeing. What we needed to do was be able to kind of help him to replace those memories with other memories, and that's the work that we could do together. So we could do some shift in that respect. So there are ways around things, I think. I don't know what you think about that, but yeah, if we think something's very sensitive or people aren't going to be able to disclose it for fear of, kind of implicating themselves in something, or because it's just going to make them more anxious to share.
Yeah.
Don't ask them for it. Let them keep that if they need to. That's my thoughts.
Yeah, absolutely. Yeah. Some really good points. I agree. I think it just depends entirely on the context. What is is that person really traumatized and it's sort of related to trauma, or is it just signaling I don't want to talk about it? It could be. I mean, I think obviously Alice has done a really good way to sort of mention supervision and discuss it. I think it's and especially kind of with the client group as well, you can sort of pose a lot more questions. But it's never something I've never really come across so far. Actually, a lot of things that the clients I've seen have been traumatized or in some way from it, but never anything against a kind of Geneva.
No, normally it's nothing that I've ever come across before either. I remember doing my counselling training many years ago and being reminded that the only things that we actually have to kind of breach confidentiality, things like money laundering, acts of terror. There was nothing about the Geneva Convention, which would have been really helpful if they'd give us some guidance on that. But I
think I was doing the right thing by, I said, discussing supervision, and then like I said, it's that kind of, is that, like you said, any immediate risk or anything that's But there will be, there might be some like we know with sort of with trauma work, there's that sometimes there is that overinflated responsibility, isn't it? Feeling overly responsible, so they might blame themselves for something that's happened, and we do that with really good trauma focused CBT work, don't we? We work through that. So that's the so that can sometimes it might present like, oh, it's all their fault, but actually we work it through.
Totally. And Alice, if you're listening, I think 2 points on that question. One being that proof that in therapy we're always breaking new ground somehow, and the second point being that if you ever need to include some kind of ethical dilemma in a portfolio of yours in the future, you've got a great one there, and now you've got audio evidence to back up the fact that you've discussed it in a variety of different fora as well. I'm also wondering, I suppose, following on from that, you referred to cases and investigations that are being brought up in relation to the Troubles, etc. I'm also wondering about the level of anxiety that might exist on the client side around the recording of this information, and how is this kept? Where is this kept? Is it likely that this data could be somehow sequestered if there is an investigation, 5-10 years in the future?
Yeah, no, absolutely. It's so far it's nothing that has come up yet, but yeah, I think it's been mindful about that sort of security and how we protect, all that information governance and that information. We do keep a focus on the needs of the veteran that's there in the clinic room, and we're working with what they're presenting with, really. So I think it's always important to just be mindful about that.
100%. Thank you for sending in that question, Alice. And if anyone else would like to get in touch and send a question our way, voice note or in text form, just email us at the usual email address, twolostsoulspodcast@gmail.com. Finally, Sam, just before we round things off for today, we spoke about one tip earlier in terms of encouraging both trainees and seasoned therapists to keep therapy active in a way and focus on the doing and not just the talking, getting out there, doing behavioural experiments, exposure work, all that exciting stuff that takes us out of the therapy room. For any trainee therapists that are listening today, any other tips that you'd like to impart with them for working with veterans?
I think we say just take the time to build that rapport. It's not easy. I think build that rapport, build that common ground with them, and I think it's not just listen. It's not just listen. They might come in and just. It's very easy. We're all guilty of it when someone comes in. But we'll try and fix this. We'll try and look at this. Sometimes just let them just talk and just take it in. Give them that time. That's what. And we talk about the standards that veterans have. They'll always be grateful for that time that you give them, and they'll always say that. And that's what. And I think that's the same for any patient really. Being just taking time to listen, and also take time to ask them about them. Why did they join the military? What was their experience like? Did they enjoy it? Where did they go? Listen to the stories. Sometimes we get some clients who just want to tell the story. And that's what we're here, especially the older veterans, and we're just here to listen, really. So, yeah, I think that's what I'd say. Don't go in expecting too much of yourself, and just take it in, really, and go from there.
Really sound advice, that. And just to round off with, where can people find out more about you or the service that you work for, or any other work that you're doing at the moment?
Yeah, so obviously I work for Veterans NHS Wales, so if you type in Veterans NHS Wales into Google, our website will come up. So we provide outpatient psychological therapy for any veteran living in Wales. But like I said, not just us, like I said, there's in England, Northern Ireland, Scotland, in the UK, there's specialist veteran services that are out there. So, if you're not sure, ask the GP, go to GP or Google, have a look around. And that's it really. Yeah, just, have a look and, you'll find us there. If you're based in sort of South Wales, obviously, as I said, you can always get in touch if you are a veteran or a veteran who might benefit from our support. Amazing.
Well, thank you for that, Sam. Thank you for coming on, and we'll hopefully chat to you again soon.
Thank you very much. Thank you for having me on. Thank you.
What did you make of that then, Shell?
I thought he was really fantastic. It's amazing, I think, that we're talking more about veterans' mental well-being and what's available. And the work that Sam's doing just sounds so valuable, so important. It's really needed, isn't it? Particularly in these small communities. The work he was talking about in the boxing gym in Port Talbot and those areas that people really need to access this kind of support. I think it's just amazing. So fabulous guest, really engaging.
Totally. And I think a brilliant reminder to all therapists out there to stay creative, stay curious and stay flexible where you need to. I think a great source potentially of inspiration to service managers and service designers as well, in terms of making sure we continue to have that flexibility to meet different demands that exist among the populations we serve. So I suppose we spoke earlier in this interview, we asked a question about, people who might be working in slightly more restrictive services. If you're finding that this system isn't allowing you to be as creative as you like to be, you tell them that you're going to be as creative as you want, and that Two Lost Souls said you can be. Disclaimer, we're not responsible for any kind of upshot from that. And there are sadly no more jobs going on the podcast either. However, we hope you enjoyed that episode as much as we did. And as we've mentioned a couple of times in today's show, feel free to reach out to us at twolostsoulspodcast@gmail.com or TLS_pod on a variety of different social networks. to just give us a shout. Let us know what you'd like to see us cover. And if you enjoyed today's episode or any of the episodes that you've listened to, please feel free to share this podcast with your colleagues, with your friends, with your families, with your dogs, and also give us some ratings on podcast platforms as well, because that is hugely appreciated by both of us. Thank you for tuning in, and we hope to see you again on an episode soon.